We are ready to let Dr. Watkins go ahead and get started. He was going to share some information about something that some of our mentors and mentees have heard about a little bit, the APOL1 variant. So he's going to speak to that. If we have a little bit of time and we have specific questions for a transplant surgeon, we've got one at least for a little bit here. So Dr. Watkins, we'll let you go ahead and get started.
All right, so thank you for the warm introductions. Pleasure to see everyone's faces. We're going to talk about the APOL1 gene. I've pulled this presentation together from other similar talks I've given, so I will simplify some of the medical figures and stuff, so don't be too alarmed. But I think this will hopefully be very informative and insightful for the team. Trying to see if I can, oh, there it is. Share my screen. Uh-oh. 1 second, folks. There's a privacy. Now it should be good. As much as okay. So in order for me to share my screen, it's going to kick me off and I'm going to come right back on. Give me 15 seconds. My apologies. These Apples are great computers, but there we go. 1 second. Okay, let's see if this works now. Perfect. Okay. I'll talk faster to make up the time. Does everyone see my screen?
Yes.
Perfect. All right. So I title APOL1, what do we know? So we know that kidney transplantation is the preferred treatment for patients with end-stage renal disease. You look at the life expectancy, the quality of life is much improved. We also know that there's a huge discrepancy, obviously, in organ supply and demand, which puts our field in quite a conundrum, and as we try to attempt to provide more organs for patients that need. We also know that there's certain groups that have a disparity in both access and outcomes in relationship to kidney transplant. For example, African Americans comprise 14% of our population, but they're comprise 30% of the people who are waiting for a kidney transplant. We know that when it comes to kidney transplantation, living donation is the optimal modality of treatment. The outcomes are better, the kidneys tend to last longer. And we also know that the number of living donor transplants have been relatively stagnant over the last couple of decades. And then when you look at the percentage of donors broken down by race, there seems to be a consistent percentage. And since we're going to be talking about APOL1, we see an uptick in the majority of races, and we're going to obviously be talking about African Americans and the implications of this variant on their outcomes. So the nidus or impetus, so to speak, for looking into some outcome issues with Black donors really came from initial studies showing that there was an increased risk of high blood pressure and end-stage renal disease in Black donors compared with matched Black non-donors. In addition, the risk of end-stage renal disease is also higher among donors who are biologically related to their recipients, and coincidentally, the majority of Black donors are related to their recipients. So the question then was, what was the effect of the donation on these outcomes, and is there some type of genetic predisposition? So the APOL1, Apolipoprotein L1 gene is located on chromosome 22. It's found in people of African descent, which I'll show you the distribution of the gene's prevalence in the world. There's two coding variants which are important, G1 and G2, because it's these variants that play a role in the suspected increased risk of chronic kidney disease in these patients. It produces a protein that's a component of HDL, but more importantly, there is a protective, right? These are variants that actually provide a protection against something called the African sleeping sickness in people who are living in Africa. So it's not all a necessarily bad thing or a bad variant. The two APOL1 gene kidney risk variants have been identified as increasing the risk of chronic kidney disease. So what that means is the normal gene doesn't cause any kidney disease, but it also doesn't protect against that African sleeping sickness. So what happens, often in biology and science is our body is smart. It has a way to kind of modify genes. So there's a protective component, but typically there's also a negative side effect of that. So another common example would be sickle cell disease and malaria. So in this instance, when you have one variant it provides protection against that African sleeping sickness, and without leading to an increased risk of kidney disease. However, when patients have both variants present, there is then noticed to be an increased risk of chronic kidney disease. And the last thing that's important to point out is that it's not just these two variants that appear to be related to the increased risk of CKD. There's also believed to be an additional hit. So it's kind of this two-hit hypothesis that plays a role. So first you have the genetic mutation, and then you have some environmental factor that plays a role, which then leads to the increased risk of kidney disease. And just real quick, here's the worldwide frequency of the APOL1 variants, purple being the highest risk frequency. So typically people talk about Western Africa as far as people from that part of Africa having the highest risk of APOL1 variants. But for all practical purposes, it's not only Blacks, but it can be seen also in Native Americans and Hispanics. So APOL, what we've discovered is that when a patient has these two variants, there's certain types of native kidney disease that exist. So there's not an APOL1 kidney disease per se, but instead it leads to people having, people with hypertension have an increased risk of hypertensive nephropathy, FSGS for patients who have HIV, it leads to an increased risk of HIV-associated nephropathy, and finally, lupus nephritis. Importantly, there tends to be an increase in unrelated forms of non-diabetic nephropathy. So we're not seeing an increased risk of diabetic nephropathy for some reason. While I'm going to focus on the living donors, obviously, because I think that's what's most relevant to this group, it is important to note that kidneys transplanted from deceased donors that had the two APOL1 kidney risk variants are associated with a twofold increased risk of graft loss compared with kidneys from donors with one or none of these variants. This is simply put, this is something called a Kaplan-Meier survival curve or graph. And the main point here is that this black line is the donors who did not have a risk variant or only had one. And you're looking at essentially their time to graft failure from the time of transplant. So this is the x-axis is years, and this is the y-axis survival. So basically you see that at 6 years, there's a statistically significant difference in graft survival in grafts from patients who had one or no variants versus this blue line, which are deceased donor transplants from patients with two risk variants. And then a study that looked at 136 African Americans who were prior living kidney donors, they followed their post-donation eGFR stratified by their risk variants to examine their outcomes. And what they found was that in comparison to donors, again, with no or only one risk variant, donors with two risk variants had both a lower pre-donation and post-donation estimated GFR. And they also had faster declines in their estimated GFR. So this figure here, this y-axis is the estimated GFR. And on x-axis, we have two groups. We have the pre-donation and post-donation groups, and we have them stratified in low risk and high risk. So as you notice, the low risk pre-donation eGFR group was higher than the high risk, and subsequently post-donation, the eGFR was actually significantly lower in the high risk group. The only thing I do want to point out is that this study was back in 2018, and for those familiar with the way the estimated GFR is calculated, this was using the CKD EPI formula that still had the race coefficient. So this race coefficient has subsequently been removed from these calculations, which actually shows a lower eGFR. So this data would actually look significantly different, and perhaps even the difference between the low risk and high groups could potentially be even magnified more, removing that race coefficient. In addition, when you looked at the rate of decline after donation, you see that the high risk group had a sharper decline in comparison to the low risk group. So this is important because you see a higher risk in donating potentially with these individuals who have these two variants. And then finally, and most importantly, because this is where a lot of the alarm kind of was derived from when it comes to looking at these donors and their risk post-donation. So out of the 19 donors out of this study who had the two hit, 11% of them developed end-stage renal disease. So if you look at this figure here, this is representing all the 19 donors post eGFR. So this black line was the average that I showed before. All these other lines represent each donor. And if you notice, there's the 1 and there's the 2 here, where their eGFR is below that 25 mark, where they're now end-stage renal disease and are candidates for a kidney transplant. The only caveat is that while this report, this study is highly cited, there was a small sample size, and there were some participants where there was an inability to genotype accurately. So this 11% frequency could be incorrect or false. So more studies are needed in order to determine what the real risk is. And finally, what about APOL1 and young healthy potential donors? So another big study looked at over 3,000 individuals between the ages of 18 and 30 who were deemed medically suitable to donate, and kind of assess their risk for development of CKD 3 or higher after 25 years. And among the 18-year-old group, they noticed that the 25-year projected CKD risk was higher in African Americans alone. Then it was higher, even higher for individuals who had the 2 APOL1 kidney risk variants. And then finally, and this is important, I think, for the medical community to really take in consideration for now, there was even greater risk noted when you had the race or the 2 hits in combination with what we call relative contraindications for donation. So impaired fasting blood sugar, for example, patients who have a BMI of over 30, eGFR of 90 to 99, so this kind of low normal range going into donation, and smoking, and then finally a family history of high blood pressure and diabetes. So it's important for, to kind of, as medical personnel, we have to risk stratify patients. And while we're still waiting for more definitive data for these APOL1 variants, patients with these relative contraindications, in addition to that, are probably at a substantially high risk for chronic kidney disease, and donation should probably not be encouraged. So until we find more information, the APOLO study is the NIH initiated the APOLO multi-center APOLO study to kind of really understand the real implications of the APOL1 kidney variants on long-term kidney function of not only donors, but also recipients. So it's important that we recognize that we have some data now, but that it's, as I mentioned, it's not definitively clear. And until that time, until the results of this study comes out, we have to make the best decisions we can for our patients with the available data. So the American Society of Transplant had a living donor community convene to kind of develop some recommendations for APOL1 genetic testing and to really advise the medical community on what the best approach is for counseling our patients while we're waiting for the Apollo study results. So they convened a group of transplant nephrologists, transplant surgeons, nephrologists with expertise in genetics. Importantly, former living kidney donors of African ancestry, right? So they wanted to make sure they had the patient's perspective and input in these recommendations. And finally, a general nephrologist and bioethicist. And this is what the attitudes about APOL1 testing were. So first, most physicians believe that all potential African-American living kidney donors should be informed about the option of APOL1 testing. African-American living kidney donors and members of the public recommended that APOL testing be routinely offered to donors to foster informed decision-making, which is going to be a very important piece of that I want to talk about in relationship to the expert guidelines or recommendations. Half of surveyed physicians stated that they would not proceed or strongly recommended against donation in potential living kidney donors carrying two APOL1 genes. Now, this line has been the source of a lot of conversations and debates at previous transplant centers where I worked, because there's an idea or belief amongst a significant number of providers that if a patient has these two APOL1 genes, then then they should not be donors. However, as this group also discovered, both African-American living kidney donors and members of the public actually oppose such a policy because their concern is donor autonomy. And what this means is obviously, how do we allow a patient to make an informed decision and have the autonomy to do what they feel that is best for them, right? So if they want to donate to their loved one, if they're okay with this potential risk, who's to say whether or not the medical community can deny that? So that's, it's important ethical debate. And here's what the APOL1 work group, the guidelines they propose, which, is really what it's been my kind of philosophy in approaching patients who are potential candidates who have these risk variants. So first, all potential living donor candidates who self-report African ancestry should be informed about the risk of the two variants. Counseling should be provided by either a transplant team or by a transplant team member under guidance of a transplant nephrologist. And testing should be offered after preliminary medical and psychosocial evaluation. So therefore, we shouldn't, provide the testing initially, but rather after there's some pre-screening done of the donor to ensure that there's no other contraindications before then providing this testing as an option to risk stratify these patients. And then this work group supported the shared decision-making between the transplant team and potential living kidney donors about donating. And so this is where it gets tricky because, if you have, when I was at NYU, we had a patient who was in his 50s. His brother, coincidentally, is a transplant surgeon. And this patient had high blood pressure, but he was only on one agent. It's very well controlled, but he was African American and he tested positive for the two risk variants. So there was a huge debate in regards to whether or not we should allow that patient to donate because the available data shows that obviously he's at increased risk, although we just aren't able to truly quantify that But however, here's someone who's older, who has a brother who's a transplant physician, and he was really adamant about donating. So you can see the ethical dilemma in regards to whether or not that patient should be allowed to donate. But fundamentally, his autonomy in decision making is important. And I'll say that in contrary example is, or example in contrast is a younger, let's say a 25-year-old donor who I've also seen, who was also an African American, who had these two variants and had a strong family history of high blood pressure and diabetes. The conversation, you still want to provide the autonomy, but the medical risks are obviously higher because this is a patient who's younger, and there's a more intense discussion that needs to be held, but you still have to, again, in my mind, provide some level of patient autonomy, in regards to the decision making. And then finally, to protect donors' privacy, the work group recommended that the transplant team should not reveal the donor's candidate's APOL1 genotype to the recipient. And as you can imagine, there's can be some intense discussions along these lines as well, because as I showed you previously, there is known data, at least in the deceased donor population, that shows that the outcomes are inferior when a donor has these two risk variants. However, it's also important to note that while the outcomes are inferior to those donors who lack the risk variants, it's still better than remaining on dialysis. So in summary, the two APOL1 kidney risk variants have been identified as kidney risk in kidney risk gene in certain populations as for reasons identified. It's important to point out that the data that we have is a very small sample size, so this risk actually might be lower than projected. And it's important to also note that there's still a large percentage of patients who have these two risk variants who go on to not have kidney problems. So it's our job to get the results from the Apollo study. So from a medical community standpoint, we will fully understand the implications of the APOL1 on long-term kidney outcomes. And then finally, in the meantime, we need to kind of risk stratify these patients, provide as much education and counseling as possible so that these potential donors can understand the risk and play a role in informed decision-making for their loved ones. And that is the conclusion of my talk on APOL1. I'm happy to answer any questions.
Dr. Watkins, this is Ned Brooks. I have a question for you. Can you hear me?
Yes, sir. How you doing, Ned?
Well, thank you. This issue of autonomy is a really interesting one in the context in which you discuss it, because I don't see why those who possess both variants would have a level of autonomy that's any different than, say, someone who has kidney stones or pre-diabetes or any one of 100 other contraindicators for being a donor. How does the autonomy of this issue differ from the autonomy on the other issues?
Yeah, great question. And the main difference, Ned, is that the best way to put it is that the majority of patients, and when I say the majority, you're talking greater than 80% who have the two risk variants actually do not have an issue with chronic kidney disease. They actually go on to be fine. So the issue is there's a small percentage of those patients, and we don't know the exact percentage, but we know that it's small, that end up developing the chronic kidney disease. So how do we make this, as a medical community, how do we take the full control of saying, well, even though your chance, let's say, is less than 10% of getting chronic kidney disease, you can't donate. And there's also this piece that we recognize that it's not just the 2 risk variants, but there's also that additional hit. And we don't know what that additional hit is. So that's where it becomes a tricky conversation. And then the last piece, which, I try to kind of allude to early on in the presentation, is that you're also dealing with ethnic group that has a higher percentage of kidney transplant on the receiving end, and therefore when their loved ones want to donate, right, how do we, there's a lot of competing issues at play, because we need these individuals to get transplanted, but yet we don't want to put your donor at increased risk as well. So it's a tough issue, and that's why there's been a lot of heated discussions. But in my mind, the short answer is, once someone is fully educated and counseled on the risks that exist, as far as we know, if they're truly adamant about donating, and they're willing to take that risk, my personal feeling is, it's not my place as a provider to make that decision for you. And I know that's not, it's not necessarily the best answer, but it does provide patient autonomy, which I think is important. Matt, I think you were first. Ed, did that answer your question?
Yes, thank you very much.
Thanks.
Dr.
Matt?
Watkins, thank you so much. To me, the real issue is you've all the signs are indicating that the risk is higher. The question is, how much higher is the risk,
Right.
of course. So what you're dealing with is decision making under uncertainty. But for you, I think your duty on some level is to inform someone about what that risk would be. When you're actually in the room talking with someone about this particular risk, how do you talk about it? And do you actually apply like a range of percentages for the elevated risk that someone might undertake by going forward?
Yeah, so that when I have the conversation, first and foremost, I often tell patients, after educating them about the knowns and unknowns, I'll tell patients what I would do, and I make a point to say that what I would do doesn't mean that's what you would do, but it's essentially relaying that based on my knowledge, and of what the potential risks are. This is what this would be my co-educated guess. The number or the data point that's typically mentioned is that 11%, right? Where, again, that's a very small study. If you think about the number of donors, right, and think about the number of African-American donors, here's one study, it was 100, a little over 100 African-American donors, and there were, 19 that developed end-stage renal disease. So it is significant, right? But that 11% is the most commonly, relayed statistic. Again, with the caveat that we really, and this is the fundamental problem, we really don't know. We really need more data. We really need more power before we fully understand the full implications of these risk variants. So we're kind of in a period of limbo, so to speak, where we want to use the best available data we have, but we also want to provide patients autonomy. Now, once Apollo study comes out, then I think the ball game changes, right? Because now we'll have this multi-center, it'll be more donors, longer term follow-up, and we can more definitively, say to our patient what the risk is. And then finally, I think the age of the donor is always really important. You're older versus younger, it's going to be two different conversations, because if you're, in your 50s and you still have good kidney function, then the odds are, you're going to be okay. Whereas if you're 20, your life expectancy is longer. In combination with what we don't know, then I'm a little bit more reluctant to kind of really, encourage it at that point, even if someone's really adamant about doing it. But it's a dilemma, as you can imagine.
When is Apollo expected to produce academically viable conclusions?
I believe within
thank
the
you, by the way,
next
thank
two.
you.
Oh, thank you, thank you. I believe within the next 2 years. So, and even if they can provide some preliminary data, that would obviously be helpful because right now we are really going off of very limited information, unfortunately. Keith?
Hey, Keith, do you have a
Oh,
question?
you might be muted.
I don't think he is. I have one. So I kind of want to turn it to the practicality for a mentor. So when mentors enter or when mentees enter our system, we don't know their ethnicity. Often, if we stick with them for any length of time, we learn what that is. Is the APOL1 testing automatically done for those of African descent, or is it a center-to-center decision?
Hello.
Yeah, it's not an automatic requirement, and I'll tell you there are some patients who don't want to know, and there are some patients who. In fact, I saw a gentleman 2 weeks ago who I strongly encouraged to get the testing because it appears that he has probably stage 1 high blood pressure, undiagnosed. And if and most centers will still allow high blood pressure if it's well controlled on one agent. Although when you add the race piece, there's some centers that won't do that. But our center will still entertain. But for him, what I relate to him is that it's important to get this testing done because it helps us risk stratify. And this additional data will be helpful because at the end of the day, as much as we want you to be able to provide an organ for your loved one, we want to first do no harm, so to speak. But he told me he would do it, and then I found out a week later that he decided to not perform the test, and that happens. I mean, it's kind of similar to genetic testing for certain diseases that can lead to cancer. Some people just don't want to know, right? They just want to see what happens, so to speak. But it's
I
not
just know
just so you know, it's not a requirement.
Yeah, as mentors, we have run into a couple situations where, as you indicated, that test is usually administered, if at all, later in the process. So we actually had one who the candidate was nearly approved, came back, must have had both variants, and the center told her she could not be a donor. Now, we also don't know what we don't know, right? We don't know other things. We don't know if she had that other list of contraindications that you shared. But, for us, it was kind of like, we didn't really even know what the APOL1 variant was. We did some quick learning, obviously reached out to someone who was an expert in you. But I mean, as mentors, I guess it's something we need to be aware of, although we don't always know the ethnicity of our candidates.
Right.
This could be something you hear them talk about, that they have to do the APOL1 test, or they got denied because of it, or that now they have to decide how they're going to proceed. So
yeah, I would encourage you if there's a mechanism where you do learn the ethnicity early in the process. I do think it's a topic that should be broached. Oftentimes, more information is better for patients in general, let alone donors. So, for example, someone might hear it from their center and may not give it too much weight, or if they additionally hear it from our group or from another mentor, then it might, I've heard about this before. Maybe this is something I should reconsider. But I personally think every individual of African descent undoubtedly should get tested. I also should point out, put out that worldwide frequencies. It's important to know we're not all homogeneous individuals by race. So there's plenty of people whose ethnic background is mixed. There's a lot of people who probably have African descent, unless they did their 23andMe or not aware of it. So I do wonder if there's a role for it being more broadly utilized versus, what people self-report or what we feel, represents that category of high risk.
great. All right. Well, thank you very much. It's been very informative. I didn't realize there were 2 possible variants and all of that, and it makes a lot more sense. So I'm sure that we'll hear about a lot of changes after the Apollo study comes out,
Yeah.
when you have that bigger data pool. If no one has any other questions for Dr. Watkins, you're welcome to stay and hear a little bit more about what we do, some information. If not, we appreciate that you came. Mike just sent